morning, everyone. I'm Leanne Griffin, on behalf of the Florida Alcohol and Drug Abuse Association. Welcome to today's webinar entitled Medication is Addiction Treatment Too, an overview of medication-assisted treatment. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note, as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them, and the presenter will answer questions at the end of the presentation. And Dr. Gastfriend, if you would like to do that in any other way, you just let me know.
That's great.
Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. If you experience poor computer audio, there are a few options to try on screen right now, and we'll also post these in the chat box. If you continue to experience a loss of audio or poor audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. And that's just www.fata.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FATA website. We value your input on all of our educational offerings, and we use that feedback to improve our online events, and we hope that you will complete the brief evaluation. If you would like to receive continuing education credits or a certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number, if applicable, for reporting to CE Broker, along with the prefix for your license number. Your certificate of attendance will be delivered to your email address within 5 business days. Note, please, that WebEx monitors arrival and departure of attendees and provides us with a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. I'd like to go ahead and introduce our presenter for today's webinar, Dr. David Gastfriend. Dr. Gastfriend is Senior Research Scientist at the Treatment Research Institute. An addiction psychiatrist, he directed addiction research at Massachusetts General Hospital and was an investigator in the NIDA cocaine collaborative study, the NIDA Combined Study, and the NIDA Clinical Trials Network. As Vice President at Alkermes, Inc., Dr. Gastfriend conducted biological, clinical, health economics, and policy research on behalf of the company's efforts in the field of addiction treatment. For 25 years, Dr. Gastfriend served on the faculty of Harvard Medical School, notably as the director of the Addiction Research Program at Massachusetts General Hospital, and founder of the MGH McLean Hospital Fellowship in Addiction Psychiatry. He is considered the world's leading expert on two important treatment tools for both the biological and psychosocial realms: the opioid blocker Vivitrol and the American Society of Addiction Medicine criteria software. Dr. Gastfriend's ASAM criteria research contributed to their endorsement by most U.S. states, the VA, and DOD. His 150 scientific publications include the ASAM criteria and addiction treatment matching. His continuum, the ASAM criteria decision engine, and ASAM's code triage are being used across Los Angeles County, the California State Prison System, Massachusetts, and elsewhere. Dr. Gastfriend's newest project is Dynamic Care Health, a technology platform for scaling up contingency management treatment and machine learning predictive analytics for routine care. He has consulted to the governments of Belgium, China, Iceland, Israel, Norway, Russia, and the United States. He received his BA at Haverford College in Philadelphia and his MD from Jefferson Medical College in Philadelphia. And we're very pleased to have David joining us today. And David, I'm going to turn control of the presentation over to you momentarily.
Okay, thank you very much. So welcome everyone, and I'm looking forward to spending the next 2 hours with you to cover this subject. And it's not just medication, but medication as a component of routine treatment, because medication is addiction treatment also. It's not an adjunct, it is part of treatment, and counseling and medication really need to work hand in hand. And I hope from what I'm going to show you, it will become clear how we should think of that. So let me start with my various disclosures. And what you'll see is that I turned from academia after 25 years at Massachusetts General Hospital and Harvard Medical School to work with industry, both the biotech and pharma industries, the technology industry, and the information industry, because I found that their capital could far exceed what the NIH could invest in addiction treatment. And I wanted to try as much as possible to bring them into working with our field. So today's webinar is focused on opioids because of the U.S. opioid crisis. And the society we live in is demanding that we use every tool in the toolkit. It's not the case that we do that. So there is a burden on us providers to change. The FDA has approved 3 medications, and that means they've determined that they are safe and effective for opioid use disorder, OUD. And those are methadone, buprenorphine, and extended-release naltrexone. And I'll mention oral naltrexone, but that has not proven to be highly effective or even to show a difference versus placebo in many studies. So I'm going to focus on these 3. Each of them has their own chemistry, their own unique brain effects, side effects, and impact on behavior. And today is an overview of all of these. So we're going to review the superiority of MAT, medication in addiction treatment, plus counseling, as opposed to counseling alone. And we'll talk about the principles for how do we select medicines for the right patient, how do we integrate the medicines with psychosocial treatment, and what are the adverse effects, the risks for abuse, and the challenges of achieving a true treatment completion. So what are the objectives we want to accomplish today? As a result of this workshop, what we want to make sure we do is be able to describe basic brain receptor actions and time courses for these 3 FDA-approved meds. We want to comprehend some of the scientific data on efficacy and effectiveness, and they're different. Efficacy is when you get a statistical significant difference between 2 approaches, the treatment and the control, the routine, the standard, placebo. But effectiveness is seeing a clinically meaningful difference in the real-world patient population. So they're really different. And we want to be able to explain to patients and their supportive others, what's the purpose of MAT? What should they expect? What should they not expect from each of these treatments? I'm going to have to go into some brain science to do this, but it doesn't all have to be super technical. We could think of this in a very common sense fashion. Let's focus on the brain's reward system. We've had it with us throughout evolution. Here is, as you'll see, a very scientific slide about brain reward throughout evolution. And it's partly a joke. In fact, it means something. It means that every advance in nature, through evolution, and even in just the determination of new fields of science, new fields of practice in our modern society, is driven by our reward system in the brain. And we can measure how drugs of abuse impact the brain. We can actually see exactly where the drugs of abuse impact the brain. And here's an example. This is where the drug alcohol impacts the brain. And what you'll notice is on the outside of the brain, you don't really see that much in terms of the activity of the brain. But deeper inside, you'll see that there are orange and yellowish regions that are lighting up. Now, in this study, they are showing social drinkers and alcohol-dependent individuals pictures of alcohol images. Those are cues, those are stimuli. And the social drinkers, hardly anything is lighting up, and the whole brain is pretty much gray and white matter. In the alcohol-dependent individuals, the outer region of the brain, the cortex, isn't really lighting up much, but a little deeper down, there's a lot of structures that are lighting up. And these are critical brain reward structures. You can see that in a person with a drug addiction, their deeper brain reward regions really get turned on when they see something exciting, their craving, their drive, desire. And this is actually shown in better format in this next slide. This is from a study in which the patients were given extended-release naltrexone, Vivitrol, and the scientists wanted to see in alcohol-dependent individuals, when they showed them pictures, or they actually used odors of their favorite alcoholic beverages, what happens to these deep brain regions? Do they get turned on or not? And what they found was, don't go bright orange and yellow, instead go down into blue. They actually do not activate at all in all of these key regions that I was just showing you before. So extended release naltrexone actually decreases activity to alcohol odors and photos in individuals who have previously been highly turned on in their brain reward region. So let's take a look at what these regions are. In a more graphic format, you see the outer region of the brain, the cortex, which is very large in mankind, and as you go down the evolutionary ladder, it gets smaller and smaller. This is where we perform decision-making, thinking, reasoning, and learning. All very important. This is what counseling addresses. Counseling speaks to the outer region of the brain. But take a look at this deeper region. This is called the limbic region. And in the limbic region, the role of these structures are basic drives and the experience of reward or euphoria. And this region is chemically triggered. It's not triggered by thought. It's not triggered by conversation. You can't trigger this region by going to an AA meeting. And yet, this, in some ways, is a more fundamental driver of behavior than the outer cortical region, because it's the limbic region that responds when we're thirsty and we see access to water, when we're hungry and we have access to food, when we're able to reproduce in mid-adolescence at the end of puberty, and we see someone who would be an exciting mate. So this region drives the rest of the brain, the thinking brain's behavior, and it's very difficult to influence things the other way around. So when we want to influence, drive behavior, we have to provide some chemical support. That's the intervention for stabilizing the limbic region. And this is a kind of simplistic picture because there are many different components of these regions. For instance, the reward region is here, but then we have to learn from those experiences of reward. So there's reward in the instant of pleasure, and then there is reinforcement, which is having that pleasure experience over and over again, leading to memory, learning of that desirable reaction. Then we have the motivation and drive centers, which takes the result of reward and balances the drive motivation to keep repeating use of these drugs over and over again against the brain's inhibitory control regions. And the inhibitory control regions, if they're functioning in a healthy balance, they balance the motivation and drive. So if the caveman is in the cave, and the caveman and his cave woman and cave baby are getting hungry, and the caveman sees a rabbit scurrying out in front of the cave, he might be inclined to his motivational drive system to run out and catch the rabbit for dinner. But if he sees the saber-toothed tiger lying in the grass, his inhibitory control system might say, you know what, we can tolerate a little bit more hunger, we can't tolerate losing the caveman here. So this go system and motivation and drive is balanced by a no-go system in the inhibitory control center. And if we go down to the cellular level, or the level of the neuron, we can actually see what chemicals are transmitting this reward. And the main chemical transmitting reward is called dopamine. It has nothing to do with dope or heroin. DOPA, D-O-P-A, stands for dihydroxyphenylalanine. It's actually amino acid. It rewards survival behavior. So when one's neuron in the center of the brain, in the reward center, is triggered to release dopamine, it releases these molecules in small amounts, but steady amounts, to a receiving neuron. And when that molecule hits the receptor, it releases a certain amount of energy into the second neuron going downstream here. So this is how dopamine triggers reward. And another chemical naturally produced in the brain is endorphin. Endorphins are associated with pain relief, stress relief, and emotional bonding. So if we have normal amounts of these, we have an ability to balance both drives and inhibition. We have the ability to signal not just reward and survival behavior, but also emotional bonding. And the brain has many backup systems. Now, this dopamine molecule is normally being transmitted from one neuron to the next neuron in the brain's reward center. That's happening at sort of a baseline, a constant, low, regular level. But when we take drugs of abuse, and we can talk about agonists first, these are opioid analgesics, the narcotic painkillers, like illicit drugs, heroin, and even methadone, which does it much more slowly and over a longer period, which is its major advantage. And this activates opioid receptors. So these little blue Y-shaped molecules are taken maybe by injection if it's heroin, and they get to the brain and bind the opioid receptor, the endorphin receptor, and that causes excessive release of dopamine. And now you see many more of these dopamine molecules, they're hitting more of the receptors, and we're getting much more energy transmitted in the reward center. Buprenorphine is also an opioid, but it's not a full agonist like methadone. It's a partial agonist. And a partial agonist means it has that similar dopamine effect, but it only goes so far. It doesn't reach the full extent of methadone. That's called a partial agonist. And the other thing that's interesting about methadone and buprenorphine is that they hit the brain much more slowly. Their onset of effect is much slower. It could be an hour or 2 hours, whereas heroin and morphine and Vicodin, they hit the brain in minutes. That slower effect makes all the difference in the degree of addiction. In considering drugs that could cause addiction, the faster the onset of the drug, the more addicting it is. So since methadone and buprenorphine are slow acting, they're much less prone to reinforcement. They still cause reinforcement, but not nearly as much as the illicit drugs of abuse. Now, what does an antagonist do, like naltrexone? Well, antag means anti, against. It's a blocker. It does the opposite of what the agonist does. And it blocks the opioid receptor. So these little yellow sort of thumb-shaped things are also going to the opiate receptor, but they are more potent. They flick into these receptors with an electromagnetic attraction, and they stay there and block, even if you take Vicodin or morphine or heroin, that can't get the opioid receptor. In fact, if you have heroin on the receptor, the naltrexone blockade is so good, it will knock that opioid off the receptor, basically. And it'll actually precipitate a withdrawal. And what happens is, now we have none of this opioid receptor or endorphin receptor triggering excess dopamine release. So we go back to normal rates of dopamine release and normal rates of reward energy being transmitted. And that just looks like this. In the brain, the fundamental region for reward, the limbic system, produces opioid peptides. They trigger increased dopamine, and that dopamine transmission tells the rest of the brain and eventually up to the motivational salient system that whatever you just did, that's good. You want to do more of it. But when we block that with a blocker, we essentially stop that transmission from happening. So that the dopamine transmission still happens, but now at a normal or what we call physiologic level. So on a more schematic basis, an agonist binds to the receptor, here's the wall of the cell membrane, and there is an effect, but if it's a slow-acting, long-acting agonist like methadone or buprenorphine, and much less of an effect than with an illicit drug or prescription painkiller. An antagonist will block that receptor, and you'll get no effect at all. How does that look in terms of graph of opioid effect versus dose? Well, with an antagonist, it doesn't matter how much dose. You could use a low dose or here a high dose, you still get no effect. That's naloxone, naltrexone, and Vivitrol. With a full agonist, the more dose you give, the more effect. The effect keeps going up and up and up. With a partial agonist, like buprenorphine, you can give more and more and more, but you're still going to reach a ceiling effect. You're not going to get higher than that. And that is part of the beauty or the safety of buprenorphine. So let's go into some detail now and talk about the neurobiology of opioid use disorder. The opioids act at these regions, on the substantia nigra and ventral tegmental area and interneurons. They bind the mu-opioid receptor and decrease GABA's inhibition of dopamine. And all you have to remember is they increase dopamine reward. That produces reward, and if it's repeated, that becomes reinforcement, and if that's repeated, it becomes learning. and a learned response. Now, there's another aspect of this that I haven't yet mentioned, and that is when the individual goes into withdrawal, that is painful, that is uncomfortable, and if you repeat it over and over again, you get reinforcement from withdrawal. But that withdrawal is a negative withdrawal, and it negatively reinforces the individual to use again and again. And that reinforcement gets learned, and it becomes very difficult to deal with because there are many regulatory changes in the brain and in the body, and they persist for weeks or months. So it's not just the first few days or 5 days of withdrawal that we may have time with detox on a residential basis to treat. It's actually something that goes on for months. Some of the things that happen are the kappa opioid receptor system gets upregulated, the stress response system that operates with steroid production in the body through the hypothalamo pituitary adrenal axis, all of these are disrupted. And what we learn from these neurobiology studies is that it's not enough to use one approach in treating this biopsychosocial disorder. We need counseling, treatment, and chemistry. The medications are essential, and we need to consider all the FDA-approved agents. Obviously, we need medical detox services. We need behavioral therapies because these really deal with the learning process, the extinction process, and the coping mechanisms that have to be learned for long-term success and recovery. And there are a number of these behavioral therapies. I'm not going to go into them today, but one of them that is quite important because it's so effective is contingency management. And we don't use these contingency management and related therapies very much at all, and we really need to. Finally, we are beginning to use recovery support services. These are critical for all the environmental stresses and things that need to be built up and arranged for successful longitudinal outcomes. So we're really trying to use all of these different approaches and to get patients to work on a comprehensive plan for recovery instead of going with a one-dimensional recovery. And obviously the goal is to overcome this epidemic, which sort of evolved because people in the community kind of got this idea that the commercial says, ask your doctor if taking a pill to solve all your problems is right for you. And we're going to have quite a challenge in our society overcoming this cultural perception that you should be able somehow to overcome all pain with a pill. So we need to fight this with both hands. We can't have one hand tied behind our back and just using counseling. That doesn't mean that the medications work for everybody or that all medications are equal or even that they have a role throughout recovery, because they don't. So what are the goals of anti-opioid pharmacotherapy? Well, there is the withdrawal management goal, that is getting people through that negative reinforcement of withdrawal, at least initially. And the important thing to remember about that is this is not considered treatment. It's important, but it's biological stabilization. It's not part of recovery. If the patient only gets detox, which is the modern name for detox is withdrawal management. If the patient only gets detox, they're not getting treatment actually. And detox without continued medication is what dominates in our environment today, in our treatment system. And that's really inadequate care. So what are the other roles of pharmacotherapy if withdrawal management isn't the end-all and be-all? Well, the next role to consider is early recovery protection, because the period of highest risk for overdose and relapse is very early in recovery after withdrawal is completed. A good example of this is what happens to people who are released from jail or prison. And the answer is their death rate is 12 times to 100 times worse than the death rate of the general population. And it depends on which study you look at. That is a horrendous figure. It means that when we imprison people, they and release them into the community without a lot of stability, we're actually exposing them to a serious risk of death. And it's because early recovery is a time when people are craving like crazy. Another early recovery goal in the early period is harm reduction. So reducing HIV and hepatitis C transmission. Even more acutely, we have the goal of increasing craving. Craving is, well, it's the sine qua non. It's the #1 driver of people relapsing early in recovery. And so our goal is to stabilize urges and impulses in order to buy time the counseling to take hold. Now, if you're not counting how many patients drop out early in treatment from your treatment program, you don't know how often craving is disrupting the counseling approach. But if you were to count this, you'd see that adding early anti-opioid pharmacotherapy and treatment right from the beginning really stabilizes patients and allows them to continue in counseling. Another goal of anti-opioid pharmacotherapy is normalizing the body's stress response, because opioid use disorder disrupts this, and the proper use of medication allows the steroid levels and anti-stress response to really stabilize across the body. There's another goal of medication, and that is to allow extinction to begin occurring. And extinction just means fading. We want that positive response to cues and the negative response to the threat of being in withdrawal to start fading over time. This can take weeks or months, and sometimes even years. And medication can really provide a foundation, a platform on which the counseling and re-exposure to cues in the environment can allow the extinction or the fading of these stimuli. There are many biological activities in the body that are unstable or destabilized by addiction, and with medication they can stabilize. So even patterns of eating, the diurnal cycle of sleep and wake, sexual function stabilizes with medications like these. The capacity for self-care, following through with activities of daily living, treatment retention, healthcare, just going to the dentist and getting your teeth checked for the first time in years, and relationship bonding. We think of that as a psychological process, but actually relationship bonding also has a chemical driver of oxytocin in the brain, and that normalizes with the medications we're talking about as well. So all of these things are critical for the early phase, and it might not be very short, it might be a longer phase. But one thing I will point out about medication is that the goal of recovery is not achieved by medication, because recovery is about disease acceptance, coping skills. It's about rehab in the bigger sense, the lifestyle change, the spiritual reclamation of a purpose in life, a sense that there's something bigger than the self. None of those are achieved through medication. So we still need all of the activities of recovery and counseling and program in order to have a complete recovery. So those are the goals of pharmacotherapy, and of course there are always interactions with drugs of abuse and other drugs, and with the treatments for drug addiction. So the good news is that there are actually fairly few drug-drug interactions with our current MAT options. But it does require that the medical team and the nursing team is aware of these things and monitors for them. There's a lot that has to do with HIV treatment medications. Obviously, other opioids, if the patient is on methadone and decides to start taking heroin or morphine or Vicodin and so forth, those can have risky interactions, and particularly with sedative hypnotics. So whereas buprenorphine is really quite safe, even in an overdose of buprenorphine by itself, if the patient adds a benzodiazepine like Valium, Xanax, Klonopin, whatever's on the street, on top of the buprenorphine, now they do have a considerable risk of overdose. So interactions with other opioids and sedatives is an issue. With a little bit with buprenorphine, a lot with Vivitrol, there's the risk of precipitating an opioid withdrawal. It's not really a side effect, but it is an adverse event. And the reason is buprenorphine will knock heroin and other opioid drugs off the receptor in the brain, and it doesn't have as strong an opioid effect as heroin or the other street drugs. So it will produce a relative withdrawal, and it'll do it very fast. Extended release naltrexone, Vivitrol, will do it immediately and will do a complete cold turkey withdrawal. But it's actually worse than cold turkey because it'll do it massively and instantly. So this is something that requires that people be withdrawn first. And we want to encourage patients to call us to report any side effects or drug-drug interactions. For more adverse effects than just these drug-drug interactions, let me talk about them briefly. There are side effects, of course, with any medication. That always is the case. And they fall into basic categories. They're serious adverse events. They're rare, especially with these medicines, but we have to anticipate them. They can include overdose. They can include precipitated withdrawal, and they may require an emergency department visit. And then there are routine, common, mild to moderate side effects, and we should be routinely advising the patients to expect those. These mostly occur in the beginning of treatment, and if you mentor the patient or if they have recovery coaches who've had some medication experience, they can coach the patient to be prepared and tolerate these. Over time, and with more experience, these occur less and less. You are going to have, throughout Florida, a peer mentor who is a physician that is trained in all of these medicines and experience and is available to talk to you by phone. I want you to call your peer mentors to report episodes of adverse events, side effects. So, number one, they can help you with those, and they can hear what's happening out in the field, and we will work together to come up with strategies to reduce these and to improve success with detox and with induction. So let's start talking about each of these medicines individually, shall we? Let's talk about the first one that emerged, and that is methadone. Now, methadone, as I said, is like an opioid. It is an opioid. The structure at the bottom of the screen is an opioid molecule. And it's a full opioid. It has the full effect, and the more you take, the more full effect you get. But the beauty of it is its slow onset. It takes an hour, 2 hours, and it lasts for 23 hours. That's actually a very good cycle for a patient who has an unregulated cycle. Because if the patient gets their methadone in the morning, they have to get up and get it. They start their day when the sunlight comes out, and they begin their diurnal cycle normalization and many other bodily functions like needing food and so forth. The fact that it lasts for 23 hours is also very useful for a patient who is chaotic and who isn't motivated highly, and because as it's wearing off, the patient becomes aware that they need to get the next dose of methadone. And so this promotes retention in the methadone program. So that's a real benefit. And there's extensive research showing the benefit of treatment initiation. It's also shown not just to promote retention and reduce drug use, but to reduce harm. The harm from HIV, the harm from Hep C. Patients who are started on methadone, who otherwise have a chaotic and poorly organized life and low motivation, they get less transmission of HIV and hepatitis C. So this is a very important service that methadone provides. And we start at a low dose, 20 to 40 milligrams, and titrate up until the patient has no craving, even when they're walking down the street and they are encountering, they see their old drug dealer. Even if they use, you want them to be on a dose, an average dose of 80 to 100 milligrams daily for most patients, so that they don't feel any opioids if they use them illegally, on top of the methadone, and they don't have craving. Now, we only have about maybe 1,300 to 1,500 certified methadone programs in the country because of federal law, and that's a limitation, and it's very inconvenient to start methadone because you have to get up every morning, even Saturday, Sunday, and holidays. Another feature of methadone is that it is prone to building up in the fatty tissue, the adipose tissue of the body. That means it's lipophilic. It likes the lipids in the body. So fat tissue buildup or accumulation causes the withdrawal at the end of methadone treatment to be slow and prolonged. So it has to be a long-term treatment because that long-term release from the body is aggravating withdrawal, right? And withdrawal is uncomfortable. It's not as severe as full withdrawal, like from heroin, not nearly as severe, it's much milder. But it's definitely aggravating and troubling to patients, and that can provoke relapse. So we have to use it as a long-term treatment. And there is one side effect to know about, and that is cardiac risk. In some patients who are vulnerable to cardiac electrical delays or conduction delays, it can prolong the cardiac waveform called the QTC wave, and there's a risk for a stoppage of the heart rhythm in some patients. So it's not common at all. It can be monitored with a cardiac electrocardiogram exam, but it's just something to be aware of, particularly if you're on the nursing or medical teams. So methadone is an excellent choice, but sometimes it could be the wrong choice, or somebody might not want that choice. And here's an example of these cute little kids. They look like twins. They're about 5 years old, and they're putting the garden hose and putting water in the gas tank, and their mom is so happy, is going to be so happy when she sees the gas tank full. So we can clearly make mistakes out of the best of intentions, and we want to understand the full purpose of these medicines, and what do we get from them? Well, here's something we get from methadone. So with methadone maintenance treatment, what's the impact on counseling and heroin use? And this is a 6-month study following release from prison, either with or without methadone. Size study, 141 individuals in the study. So with counseling alone, the percent of days in those 6 months in which people are in treatment is only 11%. That's really terrible. That means 90% of the time they're not sticking with the treatment. And let's just compare that to if we add methadone. So this is counseling plus methadone here on the right. And this blue line shows that 64%, or literally 2/3 of the time, the patients were sticking with 180 days of counseling. So this is a huge difference, 180 days versus 11%, 64% of the days versus 11% of the days. Post-release from prison, methadone is clearly not just efficacious on a statistical basis, but it's massively effective. And to deny this is probably a big mistake. We do have alternatives, and we'll get to those. Now, relapse to IV drug use after methadone maintenance is a problem. So when people are in treatment, maybe only a quarter are using relapsing to IV drugs. After people drop out, if they drop out in 1 to 3 months, nearly half are using. If they drop out after 4 to 6 months, more than half are using. And over time, the dropout rate and the relapse rate climbs. So thinking of methadone as a short-term treatment is a mistake. And it's partly because of the disease, but an even greater part may be that withdrawal of methadone provokes relapse. So we need to think of methadone as long-term treatment, and it doesn't mean that the patient does. And I'll show you data on how long they actually stick in methadone treatment a little later. But now that we've considered the molecular purpose and the time course of methadone, let's talk about who it's for. So methadone is a good medicine for a patient with a long history and a chaotic lifestyle, patients with psychiatric illness that's severe, patients who have been using benzodiazepines, and that's because the combination of benzodiazepines with high-dose buprenorphine can be an overdose risk. Patients who've been using heroin IV and have a lot of tolerance, since methadone has the full agonist effect, you can get up to a full dose of methadone that will match the degree of stabilization that the high-dose, high-tolerant heroin addict needs. The patient who needs daily close supervision, methadone is great. It will actually bring that person in because of their withdrawal starting at 23 hours. So if the patient wants to be someone who's going to have difficulty persisting in treatment, this is a good treatment. And if they're at high risk for diverting medication, you may not want to give them buprenorphine because that's a take-home, and they could be selling some of that. But methadone, you have to come to a methadone dosing window at a licensed clinic, and you get watched taking your methadone, and often in a liquid form, so it's very hard to sell. So all of these things are good for high-risk, long-term, chronic, and chaotic lifestyle patients. But the patient stabilizes at some point on methadone, which is one of its beauties. At that point, you can give take-home medication, and you can do it on a contingency management basis, meaning the patient can get the take-homes as long as their urines are staying free of opioids. But if they come back with urines that have opioids in them, then you can withdraw the take-homes and have the patient come in on a daily basis. So that is an excellent use of contingency management. Some patients will say that I don't want to be off opioids. Well, what do you mean? You came to treatment. Don't you want to be off opioids? And the patient may actually say, no, I need to feel this stuff working. I need to feel it's helping me. Otherwise, I'm going to flee from treatment. And with methadone, the patient has some subjective, very faint sense that they're on a drug. And while those of us who've done, if you've done recovery through the 12-step program, you may feel that that's a bad thing. But you know what? There's a time and place for everything. And early in recovery, it may be the right time for the patient to be at the methadone clinic. So patients like that, patients with chronic pain who need continued opioids, they can get continued opioids if it's really legitimate on top of methadone. Methadone isn't a great pain relief medicine. It's great for stabilizing craving of addiction, but the patient may need opioids on top of methadone, and it can be managed that way. That can be done safely with experienced medical providers. The patient who is pregnant or planning to become pregnant, actually methadone has been shown to be safe and effective for sustaining a healthy pregnancy. Yes, the baby is delivered with neonatal opioid withdrawal, neonatal abstinence syndrome, but that can be managed fairly easily in the neonatal ICU all over the country. So it has been a very good medicine for pregnancy, and we'll talk about buprenorphine later, which maybe is going to supplant methadone for this purpose someday. So this is for a patient who's prepared for long-term or even lifelong dosing. That's who methadone is ideal for. There is an alternative, as I said, to methadone, and the alternative is buprenorphine. If you look at chemical structures, you see this hexagonal ring. This is called a benzene structure, and the OH, the hydroxy attachment here, this pentagonal ring with oxygen, another six-sided ring here, and all of these are shared, and this bottom hexagonal ring is also shared between these two structures. Really, the major difference is in these side chains, here and here. And the side chains do make a difference, and I'll tell you what they are, but they're subtle. So the rest of this structure is really almost identical between methadone and buprenorphine, so they're quite related. And I'm just going to highlight how two things can look very similar and yet have minor differences that will help you clearly about these differences as we talk in the next section. So here are two things that are clearly very similar, and yet see if you can spot the minor differences. Okay, so this is a good moment for a little break. We have a 2-hour time span. Let's come back at 12 noon exactly. Feel free to go to the bathroom, go get a drink of water, stretch your legs, and then we'll come back at 12 noon.
Thank you, David, and this is Leanne, and as David says, we will reconvene at 12 noon. We'll be getting started in about 1 minute. And Dr. Gastfriend, whenever you're ready.
Okay, great. Thank you very much. So let's start now with buprenorphine. We talked about methadone. Here's buprenorphine's molecule again. And as I said, the effect is partial. It gets to a ceiling and then doesn't go higher, even if the patient takes higher and higher doses or an overdose. And that's a great thing. It's an advance because it means we have less overdose risk when the patient is on buprenorphine compared to methadone. And the opioid activity is actually about half of methadone's full effect. But as I said, it can knock heroin and other opioids, including methadone, off the receptor in the brain's reward center. So that throws the patient into withdrawal, at least mild withdrawal. So how do we deal with that? Well, the easiest thing is when you choose this for a patient, have them come in the next day and say, I want you to make sure that you can go a whole 12 hours to 18 hours without using, so that you are in mild withdrawal. And when you're in mild withdrawal, those receptors are unoccupied, and we give you buprenorphine then, and that will occupy those receptors. It won't give you the full feeling of euphoria or a high, but you will feel the relief of that mild withdrawal. And it has a slow onset like methadone too. Again, it can take 1 to 2 hours. That's a good thing because it makes it less reinforcing. However, unlike methadone, which runs off at about 23 hours, buprenorphine can actually last close to 36 hours in duration. And that means the next day when they take their normal daily dose of buprenorphine, they're not feeling the withdrawal, and that is also beneficial for reducing reinforcement. Now, there's plenty of research already showing that buprenorphine plus counseling extends a great benefit for initiation of treatment. And it can be prescribed in an office setting from a physician or a nurse practitioner or physician assistant who is licensed and in a state like Florida where they are permitted to obtain the waiver to authorize buprenorphine prescribing. And there are certain limitations on this. You have to take a course and so forth. But it can be prescribed daily or weekly or even once a month once it's clear that the patient is really stable in a normal outpatient office setting. And this has greatly expanded access to care. We still need many, many more providers to meet the extent of the national and Florida opioid epidemic. It is a controlled substance. It's a DEA Schedule C3 drug, and it has been expanded in the second year. A prescriber, like a physician, can prescribe for 100 patients, and actually beyond that, they can get to 275 patients. So it's approved for opioid addiction. There's a couple versions of it. The original version, which was pure buprenorphine, that was called Subutex. But now the primary use in America is a combination drug called Suboxone. Suboxone is just buprenorphine with naloxone in the pill, and there's 4 times as much buprenorphine as there is naloxone. The benefit of that is that if a new patient who hasn't been on buprenorphine gets the new pill, and they decide to crush it and inject it, the naloxone will actually throw them into withdrawal and block the buprenorphine from getting to their receptors. So in a newly initiated novice patient, Suboxone is protective against this diversion as an illegal use. In a patient who's been on buprenorphine for a while, even a couple of weeks, that really doesn't work because they have enough buprenorphine on their receptors already that naloxone isn't going to do anything. So it's really just to block novice users from abusing buprenorphine. And now we have other preparations. So we have generics like Subzol and film preparations like Bunavail. So there are different ways to use buprenorphine. How does it work in terms of patient retention? Well, here's some pretty serious patients, HIV positive, a good number, 303 patients, and they were getting the buprenorphine naloxone preparation. And at baseline, 100% are in treatment. They're all starting out in treatment. After 3 months, 25% have dropped out. And after 6 months, about 30-something percent, and by the end of the year, more than half have dropped out. So it's not, foolproof. It's not perfect. Nothing is, but it's certainly a very important additional tool in the treatment. And how can we compare buprenorphine and methadone in terms of their retention? Well, here's a study that looked at patients on high-dose methadone. This is 80 to 100 milligrams a day. And you see after 3 months or so, about 70-something percent, a high 70% group, 73% are retained in treatment. On buprenorphine, 58% are retained. Let's ignore LAM for the moment because that's not available in the U.S. Low-dose methadone, this is under 50 milligrams, is not retaining well at all. So you'll see that the methadone full dose and buprenorphine dose are retaining more than 50% for 3 months period. However, there is a difference between these. In fact, we can say a little bit more about that. There are several studies that have looked at mean or average retention on buprenorphine over time. This one from California found that patients were really retained only about 2 months. This one with 10,000 patients on methadone, buprenorphine, Vivitrol, found an average retention on buprenorphine of only, again, a little over 2 months. Freshmen in Baltimore with adolescent young adults, often who had family support, again, a little over 2 months. And this is of concern, and it's work that we have to be focused on because Roger Weiss published in the Archives of General Psychiatry a big multi-site NIDA study, which I think had 600 patients in it, and they had prescription opioid patients, so these were not street heroin addicts, but people who had been using prescription opioids, not the most severe population. They gave them 3 months of buprenorphine treatment with counseling, and then tapered them off the buprenorphine over another month. But after the end of that month, in the next 60 days, 92% relapsed. So short-term treatments, because they're followed by withdrawal, seem to produce a very high rate of relapse. And as a result, we really don't want to be seeing short-term MAT treatments with buprenorphine or methadone because they provoke a relapse. So we need to get patients to stick with treatment longer. And retention can be different depending on the dose. So I showed you that methadone full dose, 80 to 100 milligrams, is critical for retention. What about with buprenorphine? Well, this is a meta-analysis. And basically, a meta-analysis compares 2 different treatments, methadone maintenance treatment, buprenorphine treatment. And the studies generally show that methadone maintenance, the dots in the middle of these whisker lines, the dots are the average. And the dots are all pretty much on the left side of this central line. If a dot falls on the center line, it means there's no difference between methadone maintenance or buprenorphine. If it's on the left side, it means it favors methadone. If it's on the right side, and there is one study whose average is on the right side, and that favors buprenorphine. But the average is these diamonds. And when you look at flexible dose studies where people are using different doses of buprenorphine and varying them week to week for the patient, what you find is that on average, methadone is doing a bit better in retention compared to buprenorphine. Buprenorphine dosing is a little bit uncertain. And now there are 31 random controlled trials, 5,000 patients. So the evidence is moderately strong to strong, which is that flexible dose methadone maintenance treatment, where you get up to 80 to 100 milligrams, has better retention, even against buprenorphine doses up to 16 milligrams. So if the patient doesn't tolerate a high dose of methadone maintenance treatment, buprenorphine is clearly going to be the better choice. Buprenorphine has better safety. You can do it every other day, even in the beginning. You can do it monthly or weekly dosing. And it has, more convenience, and that means easier access for patients. So there are advantages to each, but we have to take into account, is this the patient who's going to have difficulty with retention? Because if they aren't, maybe methadone is the better choice. Now, is that the only difference between these drugs? No, not necessarily. Here's another difference. What about the effect of these drugs on thinking, cognition, and reaction time? So there are studies that have looked at reaction time in the first month of treatment and verbal memory deficits. Methadone has more delays in reaction time. This is things like driving simulators, reflexes, and it has more problems with verbal memory. Methadone has more of these problems than buprenorphine, and buprenorphine patients do show a difference compared to controls. Now, what about after maintenance? So the first month, people are sort of getting adapted to these meds. And we may want to tell the patient on methadone, you got to be really careful. Don't drive in the first few days after methadone. Give yourself maybe a week to get used to it. If you do a job where you're using, dangerous equipment, don't do that job in the first week of methadone. Maybe not even first week of buprenorphine until you're comfortable with these meds. What about after maintenance is established? Well, the reaction time for methadone maintenance patients on 100 milligrams, so that's a pretty solid dose, compared to control patients who weren't on any opioid. Their working memory was diminished with methadone. Their verbal memory was diminished. And that's with methadone at one dose versus another dose. So that's a pretty sensitive indicator of some cognitive effects. What about visual memory? This is looking at a stick drawing that's kind of complicated and then putting the stick drawing away and trying to draw it again. And visual memory is worse with methadone, and it's worse with buprenorphine, even just 9 milligrams, which is not a high dose, compared to controls. And driving reaction time delays, that's the ability to step on the brake when there's an accident right in front of you. That is worse with methadone than buprenorphine. So, we have to weigh these differences, and you might not be quite sure what to do. Here's one truck that says do not follow in this lane, and in the other lane it says keep left. So we've got to weigh these complicated but meaningful differences. So now we have to make that decision. Buprenorphine, for whom? Well, it's for the patient who's able to maintain some kind of a treatment plan, coming in from their home, taking meds at their home, without the daily supportive contact and structure of a clinic. Because methadone clinics provide every single day, including, Columbus Day and Christmas, an open window at the clinic. It's for the patient who has some structure in their life, maybe the patient who's employed, who's got some strong sober supports, a family or spouse who's sober and keeps an eye out on. The patient who has adequate stress management skills, who isn't using just to cope with maybe acute severe PTSD. Buprenorphine is also proving to be a good treatment for pregnant women. It stabilizes the craving, it stabilizes retention, and helps the woman pursue her OB follow-ups. The baby is born with a withdrawal syndrome. That's treated in the neonatal ICU, but babies do fine with that. And buprenorphine actually has less of that neonatal withdrawal than methadone does. It can be good for the patient who might have been put on methadone, except for their cardiac conduction wave delays. So this drug, buprenorphine, doesn't have that. And it's also good for the patient who says, I've been on methadone, I felt myself getting it every day. I was like being, for me, it was like being on a drug. I didn't want that. And buprenorphine has less of that. So if the patient wants less of a subjective sense of opioid dependence, then with methadone, buprenorphine can be a really good choice. So now we've covered methadone and buprenorphine and who they're for, but we've got a third option. So let's start getting into what is the role of extended release naltrexone, and the brand name for that is Vivitrol. So here's a study that showed pictures of people using drugs and getting people, getting drugs, but also neutral pictures. And they did it at the beginning, and then they gave them extended release naltrexone injections into their butt, and 2 weeks later they brought them back and showed them similar pictures and what happened to their brain. So here's a picture of somebody getting an injection and using a spoon to heat up heroin and liquefy it so they can inject it. And here's a picture of somebody sewing. Here's a picture of somebody cleaning. So these are the neutral cues, and these are the drug cues. And what happens to the brain? Well, here the brain is turned sideways, so it looks a little bit different than the pictures I showed you. But again, you can see the outer region of the brain isn't lighting up when the people are seeing these pictures of their favorite drug being used, but the deeper region below the big cortex, this is the region associated with reward and pleasure, and these areas are lighting up bright yellow and red. Here's a structure, the amygdala. This is sort of where the hunt response is triggered. You can see the craving is definitely turning on these areas. However, there are other areas that are being turned on that are not associated with reward. And what happens when the patient gets the Vivitrol injection? Well, here's one region of the brain before and after the extended release naltrexone. And clearly, with the extended release naltrexone, the amount of activation is going down. Here's a region before. Here's a region with the extended release naltrexone. It's going down. Here, this region is going down. This region, the activation is going down. Very consistent limbic cue responses decreasing again and again. That's great. But what's happening in these regions? Here, the activation of brain metabolic activity is actually going up when they're on the extended release naltrexone. Again, it's going up. What does that mean? Well, these are different regions. These are regions that show an increased capacity for conscious self-regulation. So they, with the benefit of the medicine, are starting to turn on again. And that suggests that this medicine isn't just reducing the reaction to cues and craving, but it's actually improving the capacity to control and to focus on recovery. So what are the principles or the properties of extended release naltrexone? Well, it's a once-a-month injection of an opioid or endorphin. That's what the mu opioid receptor means. Competitive antagonist. Antagonist means blocker. Competitive means it will compete with heroin, morphine, Dilaudid, Percodan, Vicodin, even buprenorphine. It will knock off all the other molecules that tease and trigger brain receptors. Even fentanyl. It'll block fentanyl. So that's one injection into the buttocks, First month it's on the right buttock, second month it's on the left buttocks, and every month you alternate. And it lasts for a month. And how do we know it works? Why does it work? Well, because oral naltrexone, when studied in a meta-analysis, 13 different random controlled trials with 1,158 patients, oral naltrexone did not reliably improve retention or abstinence compared to placebo. And in Canada, oral naltrexone, NTX, naltrexone PO for oral, had some deaths associated with it, more deaths, 3 to 7 times the number of deaths than methadone. So oral naltrexone has not become commonly used for opiate-dependent treatment, unless the patient is highly motivated and subject to monitoring that they're taking it every day. You skip a day, it doesn't work. Extended-release naltrexone was called for by NIH to be developed. They asked the pharmaceutical industry to please develop this month-long preparation, and it came out in 2010. The patient has to be opioid-free for 7 to 10 days first, and that detox causes a loss of tolerance, and the patient has to be cautioned that they can't go back to using the same number of bags of heroin that they used before, or the same number of OxyContin pills they used before, because they've lost their tolerance. When they're on the blockade, they will not be able, in almost all cases, it'll be very, very, very difficult to override the blockade. The blockade will be protected. When they go off the blockade, they can't use the same amount of drug they used to, or they are likely to have an overdose. And it's injected into the buttocks, so that could produce a reaction, and a bump, a lump, pain, tenderness, and even a swelling at the site. Another side effect in about 25% of the people is nausea. And it can even produce a little bit of withdrawal sensation, even if the patient's been fully withdrawn, because they are getting a blockade of their endorphin system. Now, some people have called that the naltrexone flu, but it's not really like a flu. But if you tell the patient to expect something possibly like that, it kind of helps them accept that they're going to have a few days of maybe feeling a little off. The interesting thing is that those things like nausea are gone within a few days. The naltrexone flu, those symptoms are gone by the first week. So the second injection doesn't produce these symptoms. And it is safe, in most cases, to the liver. Even in chronic hep C, even in patients with HIV. Originally, there was it's called a black box warning by the FDA, and they removed it because in studies they found there weren't any meaningful clinical problems induced by the dose of extended-release naltrexone. Another, you don't want to use it in patients who have acute hepatitis because you need to monitor their liver enzymes. And with Vivitrol, the liver enzymes can go up and down and fluctuate. So because you need to monitor those things, you do not want to be using it in people with acute hepatitis. For chronic hepatitis, it's fine. In patients who have not fully, patients who have been on it for a while and want to discontinue it, there is no withdrawal. In fact, it's self-tapering. At the end of a month, you still have some measurable plasma levels of extended-release naltrexone in the blood for days or even weeks, even out to 56 days. So we talk about it as an every 30-day or 31-day or 28-day treatment, but when the last dose is given, it actually continues to be of benefit for maybe another 1, 2, or even 3 weeks. And it's not a controlled substance. There's no street value. If it was stolen, it would not command a price. So it's the treatment of choice for certain patients. Among them are people with combined opioid and alcohol dependence, because we actually have it approved by the FDA for alcohol dependence as well as opioid dependence. And many patients with opioid dependence are also alcoholic. So it's a good medicine for this combination. And the data on it are pretty clear. So in a study of 250 opioid addicts with 10 years on average of opioid use, mostly heroin IV use, who had considerable craving even after they were withdrawn, what we found was that the placebo patients this is in the blue line here, placebo patients were averaging about 35% of their weeks opioid-free. Over 6 months of treatment with extended-release naltrexone, the placebo group in counseling, having been detoxed, 35% of their weeks were opioid-free. Not a lot, only a third. The group that got the extended-release naltrexone, 90% of their weeks were opioid-free. This is a considerable difference. It's not just significant, which it is at the 0.0002 level, highly significant, but it's substantial. And their retention is very different. The average patient on placebo is only making it through about halfway and then dropping out. The average patient on the extended release naltrexone is going through 6 months of treatment without dropping out. So that's a big difference. Again, highly significant. And how is it working? Why is it happening that way? Well, it's really interesting because if you look at the craving for these patients, they're coming out of detox. Now, this is in Russia. The study was done in Russia. And in Russia, they got an average of 18 days of detox in a hospital with all the medications for detox. So they're fully detoxed. And they come out, and when you ask someone on a 0 to 100-point scale how much you're craving, they are craving at a 20 out of 100. So they still have craving. When they get out, their change in craving, if they're on placebo and counseling, they get out into the real environment, and in the very first week, their craving jumped up. So they're actually craving more. And then it comes down, but it stays for 6 months at about where it was when they finished detox. They're still craving at about a 20 over a 0 to 100-point scale, despite all the counseling that they're giving them. They're getting good counseling from experienced people. What happens with the Vivitrol group? Well, the Vivitrol group comes out, and even though now they're in the environment where there's drug, they're not craving. Their craving is actually going down. And it goes down and stays down the whole 6 months. It's actually cut in half. So craving is decreased. The ability to get high is blocked. And that's probably why people are staying in their counseling, and that's probably why they're finishing more of their counseling compared to the placebo group. And that's why we're getting more extended release naltrexone weeks of abstinence over the course of a 6-month period. So who's it for? Well, obviously, it's for the patient who is motivated to undergo detox, for the patient who wants to be completely opioid-free. If the patient is unwilling to go through detox, you can't give Vivitrol, and you shouldn't give Vivitrol. And not everybody is willing to go through detox. It's for the patient who's preparing to leave rehab or prison or jail because hopefully they are opioid-free when they leave those places. And maybe they don't want to get back on an opioid and physically dependence-producing drug. Well, Vivitrol doesn't do that. So it's right now. It's for the patient who's being monitored, maybe by the court system or professional boards or employers. If somebody's driving a interstate shipping rig and they're monitored for the Department of Transportation with random urines, they might need to be on extended-release naltrexone instead of buprenorphine or methadone. If they're on a sports team or go to a school that doesn't allow methadone or buprenorphine, extended-release naltrexone might be the ideal treatment. If they have good structures and supports in place, they can be a good candidate for this medicine. But it's been studied whether it's only good for moderately ill opioid patients and not the severe heroin addicts with chronic disease. And what the research shows is that it's actually good for patients even with high chronicity and high severity if they want this kind of treatment. If the patient rejects agonist treatment, saying, look, I've been on methadone, I was on bupe, and, you know, I was using on those things, I'm tired of running, I'm giving up, I want the real stuff now. Well, it's not any more real stuff than the others, but if that's what the patient wants, it's best to go with what they're thinking. Or the patient who has had a very good treatment with methadone or buprenorphine and wants to conclude that. Coming off of those can be very provocative for relapse because of the withdrawal. If the patient's moved quickly onto extended-release naltrexone, and that can be done with an induction that can take less than 1 to 2 weeks. Then they can be on extended-release naltrexone sort of as a landing pad for completion of methadone or buprenorphine. If the patient is concerned, I don't want to be on this for life, and, I don't want to have to, have trouble coming down off of it, well, this is a shorter-term medication, potentially. It can be easily concluded because there's no withdrawal. If the patient is an adolescent or young adult, 18, 19, 20, 25 years old, maybe they've had a shorter duration of their addiction. Maybe the family doesn't want the patient on an agonist. Good choice. And if the patient has both opioid and alcohol dependence, as I said before. Now, we've looked at a lot of different characteristics to figure out which is the patient who has a good clinical response on this medication. And it doesn't matter what you look at. You can look at somebody who had severe global impression of severity, severe mental health functional problems, HIV status, and the percentages of success with low severity versus high severity are very similar. The high severity patients actually do well with Vivitrol. So it's challenging to figure out, so what do we choose? What's the basis for choosing? And if you look at retention, yes, you do see a difference. Health professionals, these are nurses primarily, in blue, more of them were still in treatment at the end of 6 months compared to patients who had mostly prescription pill dependence, a little bit fewer of them retained, and compared to patients in the Russian study who were HIV positive, 90% Hep C positive, 10-year veterans of heroin addiction. They had slightly lower retention, but all three groups had greater than 50% retention through 6 months. So the severity doesn't have much of a role in choosing who's the better patient for this particular treatment. And you can look at young people as well and see a similar pattern. This is retention in youth, ages 15 to 24 in Baltimore. So this is inner city, African-American, mostly youth. And the first episode retention, and if they relapsed or left and came in for a second episode of treatment, that's the total of the red and the blue. So if you combine these totals, people who were on any medication, buprenorphine or extended-release naltrexone, they had about 16 total weeks in treatment. If they were on extended-release naltrexone, almost 16, 15.3, buprenorphine, 15.9, very, very similar, no difference. All three of these, however, were significantly better, almost 50% better retention than the patient who got no medication, just counseling. So medication clearly has a benefit, and that benefit has an effect on the costs of care. So people who get medication, and that's this yellow group, over 6 months have substantially and significantly less overall healthcare costs than people who have no medication, just counseling. That is another reason society wants us to adapt and to do a better job by incorporating medication. Now, they don't all cost the same. Methadone maintenance treatment, the pill or the liquid is generic. It literally costs $1 a day. Very, very inexpensive. However, there are so many other things you have to add to that. The dosing window, the nurses, the doctors, the monitoring, that it averages $10 to $20 a day. Buprenorphine is anywhere from $4 to $30 a day. So similar range, maybe a little more expensive. Extended-release naltrexone up front is costing $20 to $40 a day, depending on whether the patient has private insurance or Medicaid, which is much less expensive, maybe $500, $600 a month. So what does that mean in terms of the breakdown of costs? Well, it depends on the utilization. People who utilize more expensive hospital services are going to cost more. So how does that look? Well, here's a 6-month insurance study that looked at all the medications patients got, inpatient costs and outpatient costs. And it's 10,000 patients. This is a big national study. And I was involved in the study. I commissioned it and oversaw it. What they found was that if you look at readmission to detox or rehab after you start treatment on one of these medicines, and the medicine is covered by the insurance company, this is commercial insured, you don't see more readmissions for detox or rehab with the extended release naltrexone. If anything, numerically it's a little less. If you look at inpatient admissions, opioid related, so maybe this is endocarditis or an injury that occurred when the patient was high, the most hospitalizations was for the group on buprenorphine. And the next highest was for the group on methadone. Pretty high, both of them, similar. They're both about double the number of inpatient admissions compared to extended release naltrexone. And if you look at non-opioid related inpatient admissions, so let's say the patient got hit by a car, was in the ICU for 2 months, but nobody took a blood sample or a urine when they came in, and the patient wasn't going to tell them, yeah, I was high on heroin when I got hit by that car. So we have to look at these costs too. And again, the methadone group is more than double the number of inpatient hospitalizations compared to the Vivitrol group. The buprenorphine group is almost double the rate of the Vivitrol group. So in each case, you see the extended release naltrexone group having less hospitalizations, less detox, less rehab. So when you add in the cost of, even with the cost of the Vivitrol, which is higher than the other medicines, the net overall cost over 6 months is greatest for the methadone group, significantly greater, almost double what the Vivitrol group's overall cost is. And even though the initial cost of the Vivitrol is high, in terms of society's overall cost for all the healthcare needs, it's not higher than any of the others. And it has less morbidity, according to this big insurance study. So that's the basis for the decision to include all of these treatments. And when it comes to criminal justice, this becomes a very important issue because the criminal justice world is having an epidemic. 67% of fatal overdose victims with a history of incarceration died within 18 months of their release from custody. So I told you about those high death rates early in release from prison. And what we're seeing is they're happening very much early on. So what happens in criminal justice when you use a medication like extended release naltrexone? Well, there's a study of that. It was published last year in the New England Journal of Medicine. And it's a good study, about 300 patients. Patients who got usual treatment started dropping out from treatment within weeks, within 2-3 weeks. A substantial proportion, over 20%, maybe 25%, are already out of treatment. With extended release naltrexone, it's taking way longer for people to drop out. They're staying with treatment much longer compared to those getting counseling, and maybe they got some buprenorphine or went to a methadone clinic. So we're seeing that retention can be good, and treatment is life-saving in people coming out of prison. In fact, if you look at mortality specifically, the relative mortality risk, and this is one of the most conservative studies, this isn't showing 100 times worse mortality risk, but it's showing 12 times the risk of death with people coming with an opioid conviction, coming out of prison, and the deaths per 100,000 person years are 12 times that of the general population within only 2 weeks after release. So this is a very big high-risk issue, and because so many people are treated, are arrested and sent to prison with opioid offenses, this is a big issue. So methadone and buprenorphine definitely decrease overdose and death rates. But despite the use of methadone and buprenorphine, rates of overdose are increasing, and rates of death with these are increasing. Extended release naltrexone also has an overdose and death risk due to the loss of tolerance when people finish it. But the reentry rates are so high that all of these medicines should be used. And that's even methadone and buprenorphine. If the patient coming out of jail, even though they've been off of methadone, there are federal laws that allow a person to restart methadone and reestablish physical dependence. That might sound a little weird, but it's so life-saving that federal rules have allowed for this, and certainly buprenorphine as well, because they work. They will decrease the death rate on reentry into the community. There are 3 extended-release naltrexone random controlled trials in criminal justice, and all of these showed very low or no deaths. So here's one from the group at Columbia, 0 overdose deaths in a 6-month study. Josh Lee and Chuck O'Brien, a multi-site study, 5 centers across the eastern seaboard. Extended release naltrexone deaths, 0. Treatment as usual deaths, 7. These are in equal-sized groups. So that's a pretty terrible comparison, that treatment as usual in the community with counseling and some availability of buprenorphine and methadone is doing so badly in terms of overdoses. Sandy Springer at Yale, New Haven, Connecticut, did a study with people who had HIV. Not only did she have no overdose deaths in her study, but a decreased HIV viral load was found as people were treated with extended release naltrexone. So all of these tools are of value and should really be used in criminal justice. What about naloxone? That's a medication. It's approved by the FDA, and there are different forms of it. There's a nasal spray, there's an auto-injector that actually talks you through how to do the injection. And these immediately reverse opioid overdose. So the patient could be comatose. And this should be supplied to all patients who are in treatment for opioid dependence, because they themselves may relapse, or they may encounter people who are using and in an overdose. Actually, anybody who is an opioid user, even if it's a prescription opioid patient for pain medication and not abusing, they should have this naloxone reversal agent on hand in their medicine chest. Families and first responders should all have this, bars, clubs. And then it's vital to engage the patient in follow-up and counseling if they are overdose reversed in an emergency room, in an ambulance, at a site where they were using, because it's not enough to just wake them up. You've got to wake them up and use that window of opportunity to engage them. And the Florida STR program is funded to develop techniques for helping emergency departments to engage and transition patients who are reversed with naloxone into treatment. So we'll be working on that with the peer mentors this year too. So how much do we actually know about extended release naltrexone? Because there's some concerns that maybe we don't know that much, and why should we be using a new medication? Well, 7 trials have been funded by the company. 3 other trials, there have been medicine provided by the company to external independent researchers. And there are 5 studies that have been conducted completely independent of the company, not even getting any medicine. So there are a total of 15 studies with 1,600, almost 1,700 patients treated for altogether over 5,000 months of treatment. And all these studies, there were 4 overdoses reported and no deaths. So there's a good bit known. And while there's more known about methadone and buprenorphine, there's certainly a sufficient amount for both the FDA and SAMHSA to say that this is an approved, accepted medicine and should be used in our treatment world. Now, the question always arises, how long should a patient be treated and how do we follow up? And there will be a session on this later in the year to go into detail, but basically the principles are as follows. Opioid substitution with methadone or buprenorphine has to be long-term because the patient will withdraw even when they're tapered slowly, and that frequently causes relapse. So the patient has to acquire many strengths thanks to the counseling and their lifestyle changes and participation in fellowship, hopefully, in order to withstand that withdrawal. Vivitrol doesn't have that. What's only needed as long as it takes to stabilize the craving and establish acceptance of the disease. So clinicians should work together with patients in the midst of counseling to determine how long the medication-assisted treatment should be administered. And it's based on how well is the patient engaged in treatment and recovery efforts and their functional progress. And there is a model for this, and that is the ASAM criteria as a way to assess this. After the patient is discontinued on their MAT, are we done? And the answer is no. We need to do post-medication outcome tracking. We need to look at disease as chronic and relapsing, and therefore we should be continuing to assess the patient's risks and track the patient and determine if they need to restart it at some point, and preferably before they're fully physiologically dependent. Because if you can catch the patient before they've reestablished dependence, which can take days or weeks, then you don't have to have the patient go through detox necessarily. And you want to get the patient in a relapse before they have other injuries or losses. And you want to have contact with the patient so that if they relapse, you can catch them during a window of opportunity. You don't want them to go 6 months being sicker and sicker and feel ashamed and not want to come back. First of all, they'll come back to a different program. If they're ashamed of relapsing after they got out of your program, they'll go to a different program, and you'll lose that patient. Whereas if you stayed in touch with the patient with follow-up phone calls to the patient and their support person, you're going to be able to re-engage them more quickly and right back into your program. And it's not just the clinic or the counselors. The physicians themselves should have some way of finding out how the patient did and judging or advising the team whether the patient needs to return for reinstatement. So let's keep all of these needs in mind. It's a chronic disease. It needs both medications and counseling. The goal of treatment is first to save lives and to stabilize behavior. And yes, we want to establish social function and produce recovery, but we have to go in a sequence according to where the patient is at. Agonists and antagonists are clearly superior when combined with counseling than counseling used just alone. So if you're just using counseling, really it's time to change. They're all appropriate first-line approaches, but depending on what the patient's needs and wishes are. A program should provide all of these 3 options and inform the patient with good information about all these options. If you only use one or only use another, that's really not adequate care. No other medical specialty or area of healthcare. If you went to an oncologist with your sick mother and the oncologist said, well, there are different approaches, we only like to use this one, you'd be out of there in a flash to find someone with a second opinion. Why is a different treatment not deserving of the same kind of excellent care and quality that we have in other healthcare specialties? And when it comes to money, low initial costs can be high costs later. High initial costs can result in lower costs later. The cost really shouldn't be the consideration. Patient choice is probably the best basis for drug selection. And if one medicine is started and the patient doesn't seem to be stabilizing or liking it, then try the other option. There are many choices. There are other items coming on the horizon. LAM is not going to be used because of some side effects. There are other forms of extended release opioids. There's vaccines. Probufene, which is the 6-month buprenorphine implant, actually is approved and is being marketed. And it requires a little surgical insertion, which a family practitioner can do, really. It's not complex. And the retention compared to placebo has been very good. So this is a good option, long-term buprenorphine. We have to be careful because the media is constantly looking for a headline, and the media does not necessarily have a rich or full understanding of how difficult this disease is to treat. So even in an investigation that's, extensive and detailed, like the New York Times feature studies, this Sunday Review feature article on buprenorphine did a terrible thing, terrible disservice to people with addiction. They put a headline, "Addicted to a treatment for addiction," about buprenorphine. This is really counterproductive in our current environment. And they don't just do this kind of headline seeking with a drug like buprenorphine. Here's another example. This is another New York Times feature story just a month later on Vivitrol. Seizing on opioid crisis, a drug maker lobbies hard for its product. Well, every drug maker lobbies for its product. And if the product is a good product, why wouldn't the drug maker lobby hard for its product? But this is all about trying to sell newspapers, and unfortunately, it's at the expense of our patients. So when things come out, when they're new, we don't want to be negative. We don't want to stand off. We want to consider things and evaluate them on their own merit. By the way, it's natural to reject things that are new. This is reactions in the press to the Beatles when they first emerged. And David Susskind, who was a very famous American TV host, stated, "Most repulsive group of men I've ever seen." And it just shows you how our perspectives change as we get more knowledgeable about these things. There are many myths. There's many ways to be negative about MAT. Thinking that the gold standard is abstinence. Well, no, the gold standard is health, it's function. And if the patient is at risk of death, he's staying alive. So we have to be more flexible, and we can change our perspective on the gold standard in a given patient over time. I don't even like the term medication-assisted treatment. You wouldn't call insulin medication-assisted treatment for diabetes. Yes, it's a behavioral disorder. You have to diet, you have to exercise, but diabetes is treated with insulin as medication in diabetes treatment. So maybe we should be using this abbreviation, medication in addiction treatment, and normalize it. There's a myth that there's a lifelong endorphin deficiency in opioid addiction, and there's essentially no evidence of that. Long-term treatment is the norm. It should be the norm with methadone and buprenorphine because withdrawal that they induce on conclusion. But it's not the norm. So the myth that these are long-term treatments is a problem, and we have to work hard to retain patients. The counseling is important for doing that. So they are reinforcing, and we have to help patients get all the strengths and resources so that when they decide to come off, it's really the right time. And the cost of treatment should not be the issue. When motor vehicle accidents in America peaked, the American Congress mandated airbags. They raised the cost of the average car in today's money by $1,000. And guess what happened? People stopped dying at such high rates from motor vehicle accidents. Overdose deaths now surpass motor vehicle accidents. Well, what do we feel we can spend on people who are dying from this cause as opposed to dying from a car accident? We wouldn't license automobiles nowadays that omit seatbelts or headlights. We wouldn't accredit hospitals for bypass surgery if they lacked a cardiology department. So when we think of our disease and we want to be treated with respect accorded to other healthcare providers, we can report 5-year outcomes in cancer and heart disease. We should be thinking about retaining patients, having outcomes on them for a long period of time too. And finally, is it ethical to mandate treatment and medication in criminal justice? Well, there was a national ethics conference a few years back that asked, is it ethical not to mandate these? Because patients need these in order to have their best outcomes. So there are a lot of things that are unknown. One is that you have to normalize transmission of endorphins in the brain when you're on methadone and buprenorphine. There's research looking at that, but it's really unresolved. We don't know. So there are many unknowns and research needs. So I'm just going to finish up with the conclusions that opioid use disorder is chronic and needs long-term treatment, and that should be meds plus counseling. Save lives, stabilize behavior. And it's the combination of these medicines with counseling that is superior to counseling alone. So the best basis for drug selection is patient choice. And if one agent is unsuccessful, have the others at your disposal and use all of them. So let me stop there, and let's see if we have any questions. And I'm not hearing anything.
Dr. Gastfriend, were you calling for questions?
I am, yes.
There was one that came in, and you may have addressed it, but actually we have a couple that have come in. Are you ready to take those?
Please do.
Okay. This one says, I am hearing more about off-label use of oral naltrexone for things like depression and fibromyalgia. What do you know about this?
Yeah, okay, good question. There is some use emerging of oral naltrexone, sometimes in low dose, for a whole variety of things. It's not proven. The literature is very early, and it's not very clear. Even for migraines, it's been tried. And I really don't have a strong opinion about these. I think that a lot of it is subjective, and you know, we don't have scientific markers for these things. So I'm holding off on my recommendations at this point.
Thank you, Doctor. I have one other question. It's related to the clinical opiate withdrawal scale. And the question is, what clinical opiate withdrawal scale score, in addition to symptoms, are you recommending for administering the buprenorphine?
Oh, okay. Well, the COWS is a good scale. I don't think you need to even worry about a score on the COWS, because if the patient is having any ongoing subjective symptoms of withdrawal, they are already in enough withdrawal so that you can go ahead and initiate buprenorphine. So it's really fine if the patient is having, you know, early withdrawal symptoms subjectively. Now, if you're going to use the COWS, fine. In terms of an actual score, I'm looking up the, you know, even if you're in a 5 to 12 mild withdrawal range, that's enough withdrawal that when you give a partial agonist effect, that's going to be sufficient to convert the patient to buprenorphine and have them become more comfortable.
Thank you. At this time, Dr. Gastfriend, if you're ready, I'll take control back over the presentation and we'll begin our conclusion.
Sure.
Thank you very much. All right, that concludes the Q&A portion of our webinar. Thank you so much, Dr. Gastfriend, for your time with us today. We very much appreciate it. And I wanted just to remind all of our participants that when you exit the event today, when we close it, your browser is going to take you to an evaluation form on the FATA website. You'll also get a second opportunity to complete this evaluation. If you have any trouble getting directed automatically from your system when we close the webinar, you will receive a follow-up thank you email that will have embedded in it another opportunity to complete the evaluation. And of course, you'll want to do that in order to get your certificate of attendance and your continuing education units as appropriate. Again, your certificate of attendance will be delivered to your email address within 5 business days. And we'd like to go ahead and just once again thank all of you for participating. We had a very good turnout for this important presentation. And that concludes our webinar. Please always be on the lookout for future FADA webinars that we conduct. And also, we want to thank the Florida Department of Children and Families, the Office of Substance Abuse and Mental Health for the funding of today's webinar. Thank you very much. And again, Dr. Gastfriend, thank you.
Oh, you're welcome. Good luck, everyone.